Hello, in this video I will be reviewing cardiac arrest algorithm and Hs and Ts. Once the patient is identified unresponsive, not breathing and without a pulse, immediate CPR is initiated with addition of supplemental oxygen and connection to the monitor defibrillator as soon as possible. After connecting defibrillator, we can analyze the rhythm that will take us down one of the two pathways. One of them is ventricular tachycardia, ventricular fibrillation, where the heart rhythm cannot produce a pulse. Immediate defibrillation is required with 120 to 200 joules on biphasic defibrillator and from 200 to 360 joules on monophasic defibrillator. After defibrillation, immediate CPR is required. Even if defibrillation is successful, the heart at this point is likely to need the support of the CPR. After the first shock, if not already established, IV or IO access is recommended to be placed. Recommendations for CPR are 30 compressions to tube ventilation if not intubated for 2 minutes, then rhythm check and pulse check. Once patient is intubated, it is continuous CPR for 2 minutes with 1 breath every 6 seconds. Then rhythm and pulse check. This can be done simultaneously and it will not interfere with the reading. If ventricular fibrillation or ventricular tachycardia is still present, shock is advised with 200 to 360 joules. After second shock, CPR recommended to be resumed immediately, and 1 mg of epinephrine can be given. 1 mg of epi can be given every 3 to 5 minutes. Considerations for advanced airway and connection to capnography can be made at this time. Capnography is a very useful tool during the code, where capnography can provide information on effectiveness of compression and return of spontaneous circulation. After 2 minutes of CPR, pulse and rhythm check is done. If ventricular fibrillation or ventricular tachycardia is still present, shock is advised. After delivery of the shock and resuming of the CPR, 2 medications are considered, amiodarone and lidocaine. Both calm the myocardium and stabilize electrical membrane. Amiodarone can be given first dose 300 mg and second dose 150 mg. Lidocaine is weight-based. It is first dose 1 mg to 1.5 mg per kilogram of body weight. Subsequent doses are 0.5 to 0.75 mg per kilogram of body, with a maximum dose of 3 mg per kilogram. That is the first dose if it's 1 mg, and the 4 additional doses of 0.5 mg per kilogram of body are possible while alternating with epinephrine. If at any pulse check and rhythm check there is asystole or pulseless electrical activity on the monitor, then pathway of the algorithm is changed to second pathway, asystole pulseless electrical activity, where there is no shocks, amiodarone or lidocaine, only delivery of compressions and epinephrine every 3 to 5 minutes. So following the second pathway from the beginning, if after initiating the CPR and determining the initial rhythm on defibrillator as asystole or pulseless electrical activity, which is a rhythm that should produce a pulse, but it doesn't, 1 mg of epi is given and CPR is continued. At this point, IV-IO access is placed, if not already established, and consideration for advanced airway is made with connection to capnography. After 2 minutes, second pulse and rhythm check is made. If asystole or pulseless electrical activity persists, just CPR is continued. It is important to determine the reversible causes at this point and treat it. Reversible causes can be classified in several ways. One of them is Hs and Ts. Under H's category of possible causes that led to pulseless electrical activity or asystole, the first on the list is hypoxia. Diagnosis can be supported by frequent airway issues, desaturations, bradycardia, cyanosis. Treatment is effective airway, such as endotracheal tube, supplemental oxygen, and bag mask ventilation. Next is hypovolemia. Diagnosis can be supported by trending low blood pressures, narrow QRS, rapid heart rate, flat neck veins. It is treated by stopping the loss of fluids, administration of supplemental fluids, and consideration of possible vasopressors. Next is high hydrogens, ions, which is the acidosis. Diagnosis can be supported by ABGs, low amplitude QRS complexes, and treatment will be with bicarbonate and ventilations. Next is hyperkalemia. Diagnosis can be supported with labs, Hict T-wave, white QRSs, cramps, renal failure, and diabetes. It is treated with calcium chloride. Calcium chloride stabilizes the cell membrane. It does not have any effect on serum potassium level. Insulin with AMP of D50 will push the potassium into the cells, as well as albuterol and sodium bicarb. They promote temporary potassium shift from extracellular to intracellular space. However, later treatment to lower potassium may be dialysis, loop diuretics, and K-oxalate. Next is hypokalemia. Diagnosis is supported by labs, low T-wave, U-wave, white QRS complex, cramps, and history of diuretic use, and is treated with magnesium. Magnesium helps retain potassium in the body. It prevents loss of potassium in urine and GI tract. Next is hypothermia. Diagnosis is supported by low temperatures below 35 Celsius, Osborne wave, which is depicted over here. This little bump next to the QRS is the Osborne wave. Other signs and symptoms are slow or absent heart rate. During hypothermia, electrical activity of the heart slows down. Pacemaker cells fire less and less. Eventually, heart stops. Treatment is rewarming in a controlled way with such tools such as bear hugger, warm IV fluids, increasing room temperature is helpful, and warm blankets. Now on the T's. Tension pneumothorax is diagnosed by difficulty ventilating with a bag valve mask or through the endotracheal tube, absent lung sounds on one side, and tracheal deviation, also by chest x-ray. Treatment is with needle decompression, second intercostal space, mid-clavicular line, and placement of the chest tubes. Next is pulmonary and coronary thrombosis, diagnosed with electrocardiogram, X-ray, ultrasound, CT, treated with surgical embolectomy or strong thrombolytics such as TPA. Cardiac tamponade, diagnosed with muffled heart sounds, narrow complex QRSs, rapid heart rate, ultrasound such as echo of pericardial sac, and is treated with needle decompression, pericardiocentesis. 20 cc's of clear fluid is a good result, and if it's bloody, it's bad. Toxins can be the cause of pulseless electrical activity, such as overdose of calcium channel blockers, digoxin, tricyclic antidepressants, treated with antidotes per tuxidrome. That could be supplemental calcium for calcium channel blockers, fluids with glucagon for beta blockers, digoxin immunophob for digoxin, and sodium bicarb for tricyclic antidepressants. Emerging trends focused on using measurements of QRS and ultrasound at the bedside during the code to locate the cause of the pulseless electrical activity or systole, such as hypovolemia, obstruction, or heart and electrolyte problem. If the QRS is narrow, then it is more likely a problem outside the heart, such as hypovolemia or obstruction, and the heart itself is functioning appropriately. Obstructions such as pulmonary embolism, tension pneumothorax, cardiac tamponade, or hypovolemia. If the QRS is wide or the electrocardiogram itself is abnormal, then it is more likely hypoxia, abnormal potassium levels, acidosis, drugs, myocardial infarction, hypothermia. That is effective if the QRS was not wide from the past medical history. Ultrasound is used to differentiate between pulmonary embolism from hypovolemia and cardiac tamponade. History is also important. The likelihood that what brought them to the hospital could be the cause of pulseless electrical activity is high. Here are some examples. End-stage renal disease. Possible cause is acidosis, high potassium levels, pericardial effusion. Nausea and vomiting. Possible causes hypovolemia, electrolyte imbalance, low potassium, alkalosis. GI bleeding. Possible causes hypovolemia. Status asthmaticus. Possible cause is hypoxia. Patients with COPD on a ventilator, possible causes tension pneumothorax from ruptured lung. Trauma patient, hypovolemia, tension pneumothorax, cardiac tamponade, fat embolism. Psych history, tricyclic antidepressants overdose. History of atrial fibrillation. Possible cause could be digoxin overdose, calcium channel blocker overdose. After all this said, all of this information is for consideration and educational purposes only, and different facilities' policies should be followed. So you just made it to the end of the video. If you found the video useful, please click that like button. I hope you enjoyed it. Thank you for watching, and I wish you great success.